So, good morning, everyone, and welcome to Integrity House. I'd like to welcome my colleagues who are in the addiction treatment field, and also the people in recovery that are here to join us today. I'd like to welcome the commissioners, Commissioner Blake, Richmond, Connolly. There's another commissioner here, Bennett, and the Attorney General, Perino. Attorney General. There we go, there in the back, okay, with the Integrity House crowd, very good. So, Integrity House is honored to welcome our country's most passionate and influential person leading the fight against the opiate epidemic. Please join me in welcoming a champion for individuals and families who struggle with addiction, and a champion for those of us who are living and thriving in the Recovery House community, in the Integrity House community, Governor Chris Christie.
Good morning, everyone. Thank you very much for being here. I want to thank the folks at Integrity House. They do extraordinary work here. Mary Pat and I both have had the opportunity to be here a number of times, and we both really feel honored to be a part of the Integrity House family and to be part of what you do here. I also want to thank the members of my cabinet who are here. What we're announcing today would not have been possible first without the hard work of Charlie McKenna, who has chaired our group, our study group on opioid addiction. His report will be released this week, and the basis of what we're doing here was set through Charlie's work and his coordination with folks all across the state government. So Charlie is the guy trying to hide in the back next to the Attorney General. So I've just ended his anonymity for today, despite his best efforts. I obviously also want to thank the Attorney General for his commitment to every aspect of our efforts on opioids, not just treatment, but also interdiction and prevention for kids all across the state. I also want to thank my other cabinet commissioners who are here: the Commissioner of Human Services, the Commissioner of DCA, the Commissioner of Children and Families, the Commissioner of Health. This has really been a joint effort among 8 different cabinet departments. I spoke to them right after the budget was done in July, and told them that one of the things that we fought for in the budget was the ability for the governor to be able to move money from any line item in the state budget to address a public health crisis. And that was one of the reasons that we fought as hard as we did on the budget for money to deal with this problem through a number of different avenues. And when the legislature closed off one avenue, we made sure that we opened up another. I was going to get this done no matter how hard the Speaker of the Assembly tried to prevent us from helping the poor and the disadvantaged in this state who need additional treatment and care like this. I'll never quite understand. I have a number of theories, so I'll never quite understand how the Speaker could be against it, but we'll leave that for another day. As today, we're happy to announce this new package of initiatives, committing $200 million to expand effective programs and launch new ones that will enhance the holistic approach needed to combat New Jersey's opioid crisis. We're addressing the widespread toll that addiction is taking, not only on those with the addiction or use disorder, but just as importantly, on the families and the loved ones around them every day who suffer just as much as those who are going through the addiction themselves. We know this is an incredibly complex human problem that requires complex but coordinated and symmetrical efforts to deal with it. We cannot continue to do what we've been doing, those things that have not been successful. We need to replicate those things that are successful. From the start, we've worked to intensify public education and prevention programs, knowing that the best way to address addiction is to have everyone keenly aware of how it begins and understand the signs to look for in your children, your brothers, your sisters, your parents, and your friends. And I see Vanessa Fatola here today. She and I spent a good amount of time at the governor's mansion last week preparing the next round of television ads, which will begin soon, on the issue of particularly of families knowing the signs to look for. And Vanessa did a great job, as you'll see in those ads that come up, and she has become an extraordinarily credible and believable spokesperson as someone in recovery herself for what we need to do. And we want to get to medical providers also. We want to make sure that they understand that every patient that comes into their office is someone who is dealing potentially with an addiction issue, and to look for those signs before a mother winds up driving the streets of a city looking for her lost daughter, who, because of an addiction that began with an overprescription of pain medication after an injury, is now avoiding coming home in order to feed her heroin habit. The crisis is upon us, well upon us, and the people in this room know that. So do thousands of other families across the state. We can't say we're going to focus purely on the prevention and wipe our hands of those who are already lost in the carnage of addiction, people whose addiction is already impacting everyone around them. This is where many of these 25 new initiatives we're launching today come into play. These initiatives will build on the dozens of major programs we've already launched during my time as governor. And as with our past initiatives, we continue to acknowledge that there is no one silver bullet to address addiction. People need individualized treatment and then wraparound support services to help prevent them from succumbing to the deadly and costly throes of relapse. Indeed, addiction is a lifelong battle. It is a chronic disease, and we need to treat it as such. We always say we do not have a treatment bed problem in New Jersey. We have a relapse problem in New Jersey. And if we dealt with the relapse problem, we would not nearly have a treatment bed problem that we have today. In any given treatment center, you have people who are in treatment programs for the second, third, or fourth time. That can be fixed. Recovery from this disease is difficult, and it requires a great deal of support. Today, we're recognizing that and are working to bridge the gaps that we've identified over the years that we've been looking at this problem. From my office, I have a bird's eye view of how state departments have been involved in dealing with this crisis. And from that position and years-long relationships that I've built with many organizations involved in this fight, with their advocates and their families who are both directly involved with this issue and impacted by the crisis, I know how they can best implement programs for all people, regardless of age, race, ethnicity, geographic location, or socioeconomic status. None of those things matter. This is a non-discriminatory disease. They'll take anybody they can. At the core of this new package of initiatives is the mobilization of resources of a number of state agencies and departments. In human terms, that means we'll be saving more lives and reaching more people than we reach today. For example, as part of this package of initiatives, the Division of Mental Health and Addiction Services is rolling out a pilot program where treatment providers get incentive payments based on clients staying in active treatment, being employed, having stable housing, and the other things that we know help with recovery. If someone's homeless, it's hard for them to stay in recovery. If someone's unemployed, it's hard for them to stay in recovery. If someone is not going to their outpatient treatment, it's hard for them to stay in recovery. We want to incentivize those who are providing this treatment to know that at the end of however long their inpatient program is, that their obligation does not end to that patient and to their family. So we're dedicating $40 million to this effort. This is going to be the gold standard of care across the entire country when we get done. Well, this program will be for New Jerseyans with an opioid addiction who are on Medicaid or are uninsured. It's our hope that this will serve as a model for other treatment providers to use with their populations as well. Middle-class people who struggle financially when seeking treatment for a loved one, but who don't qualify for public assistance. Because we don't have just one treatment system in New Jersey, we have several, and we can't focus only on Medicaid enrollees or those involved just with the criminal justice system. We have to help the middle-class families who make too much to qualify for public assistance, but don't have tens of thousands of dollars to pay for treatment when insurance turns them away. To that end, we're providing funding to the Mental Health Association's consumer advocacy services that have professionals training to advocate for consumers when they run into insurance barriers. They need people to help them to fight the insurance companies when the insurance companies don't want to pay, and we're going to help to do that as well. The goal of these initiatives is to address the day-to-day issues that may not be immediately recognized outside of a family dealing with addiction. These have come in large part from the stories that I've heard in places like this, from both addicts and their families, about the real life problems that they confront in addition to the addiction. Consider just one aspect of how the opioid crisis is impacting our society. Since 2011, about 6% of all infants born in New Jersey experience neonatal abstinence syndrome, a multitude of problems that stem from a mother with an addiction problem during the pregnancy and while giving birth. Newborn babies are too often innocent casualties of this crisis. Think about that. 6% of all of the children born in this state in the last 6 years have had this problem. And think about what the impact of that will be on those children for the rest of their lives. It's unacceptable. I held one of these newborns in my arms last December at Jersey Shore Medical Center. Sat there with this child's grandmother, who was caring for this baby because the baby's mother was in the throes of addiction and incapable of caring for the child. When you get that close to what people would call a societal problem, you're not thinking about statistics. You find yourself asking yourself, how did we get here? And what can we do to help this child and to stop it from happening to other children in the future? Treating pregnant women with addiction requires us to address their addiction while reducing and hopefully eliminating the chances of exposure to their unborn children. One of these initiatives we're launching involves the Department of Health, using $5 million to create and expand the amount of residential treatment sober homes for pregnant women and new mothers with substance use disorders in northern, central, and southern New Jersey. We visited such a program. I think we're going to go back there later this week. The Center for Great Expectations, which Mary Pat and I were so impressed with when we visited it that we've now become private supporters of their mission as well. Think about this place. A couple of times over the years, I've had the opportunity to sit and one-on-one speak with new mothers who, without the help given to them by the Center for Great Expectations, would have been juggling their addiction, their newborn baby, and the challenges of being homeless. It's almost unthinkable. These programs see women through pregnancy, keep them sober through birth, and develop plans for them to remain sober and live productive lives as they meet the challenges of every new mother, often a single mother, and what they face in society. At the same time, we want to expand early detection measures to reduce the number of women and newborns who are in this situation. So the Division of Mental Health and Addiction Services will put $1 million towards identifying counties with the highest incidence of women who are pregnant and addicted to opioids, then provide counselors in health clinics in those locations to identify and work with addicted mothers and refer them to services that already exist. Often, these women don't know where to go. They don't know where to turn. It makes no sense for me to establish all these programs, but then have the people who need them the most not know about them and not know how to get there. This person will be, this group of people will be folks who will direct women who are having this problem to get the treatment they need as quickly as possible to try to prevent their child from suffering from the very same issue. Additionally, the Department of Health will be launching an opioid campaign to connect with obstetricians who can help advise women on prevention and also help recognize and report high-risk cases that may be addressed through additional referrals to other programs. We don't think of OBGYNs as being addiction treatment providers, but when hundreds of babies are born each year in withdrawal from opioids, we need OBGYNs to be better educated and to get more involved. It's not just bringing a life into the world, it's bringing a healthy life into the world. And we need our OBGYNs to be better educated on this, and the Department of Health is going to help to lead the fight on that as well. Let's look at another population with unique issues surrounding their addiction and how the same departments can help. One of our initiatives includes spending $36 million to expand supportive housing for adults with substance use disorders, often low-income people who need to be outside of the neighborhoods or the life situations that help to lead them to the addiction in the first place. Imagine if the neighborhood they come from and the folks they associated with in those neighborhoods are the very people who helped lead them to this addiction. And we make treatment available to them, and they come out in recovery, but return to the very same places with the very same influences. And we think for some reason that they won't fall victim to that. Well, maybe some won't, but too many do. And so the supportive housing will offer not just a safe and affordable home, but additionally an opportunity to learn job skills and interviewing techniques to rebuild their lives on the outside. And we almost always will try to put them in a new location, someplace away from the neighborhood that may have helped to lead them to the problems that they confronted when they got into treatment in the first place. This past February, I visited the Trenton Rescue Mission, which has this type of program already working. One man there was completely candid with me. He said, if I hadn't come over here, I'd be 6 feet under somewhere. That's how bad my addiction had gotten. What he also said is he had learned, along with some skills in interviewing for jobs, he learned most importantly to love himself, which he said he had never done in his whole life. He said he didn't care about himself or the heartache he delivered regularly to his family, but that through the treatment that he received at the Trenton Rescue Mission, that he was able to understand that he first had to love himself if he could, before he ever could, love his family and those people around him. In our visit, we heard firsthand how staying sober and out of trouble with the law was difficult for folks who came into the situation poor, out of work, and stuck in a neighborhood where the situations that enable their tendencies towards substance abuse continue to surround them. Again, to help people recover is more than just getting the treatment and then getting them back out the door. With addiction, with many people, we need to address a host of related problems to keep people on the path to recovery. I will also tell you that this program expends another $21 million on our Recovery Coach program and expands it now to every county in the state. This is an extraordinarily important program, and we have seen in our pilot counties already a significant reduction in relapse from folks who have been brought in to an emergency room, been administered Narcan to reverse an overdose. And instead of just being asked one question, which is, have you thought about committing suicide? And if the person answers no, they're released from the hospital. No detox, no advice for treatment, just right back out onto the street. And we've seen the statistics that those folks over and over again come back. I heard one story here at Integrity House about a young man who told me that he was in the hospital for his either 5th or 6th Narcan reversal, and he had another guy next to him who had been reversed even more times than him. And he heard them asking the other guy, have you thought about committing suicide? And the guy said yes. They said, okay, well, we need to admit you then for at least 3 days to observe you. The doctors left, and they were in the same bay in the emergency room, and he turned to the guy and said, wow, you really thought about committing suicide? He goes, no, I didn't. He said, but now I'll get detox. He said, because if you tell them that you're going to commit suicide, they keep you in for at least 3 days. And in those 3 days, I can detox. So the guy next to him, who was here in Integrity House, then said, well, the next time I overdosed, and got, now think about that. He was sitting there planning, well, like, okay, so when I overdose the next time, and they revive me with Narcan the next time, I'm going to tell them I tried to kill myself so that I can finally detox. There's got to be a better way than that. And the Recovery Coach program is one of those ways. So what will happen now in every county in New Jersey starting this fall? If someone's brought into an emergency room in any hospital in this state, after they're revived and their general health is assessed by the healthcare professionals in the hospital, they will then be met by a recovery coach. Most of the time, someone who is in recovery themselves long term. Someone who can speak to them in the language that they can understand. Someone who's been there and has experienced exactly what they are experiencing, and be able to push them towards an appropriate detox facility, get them to inpatient treatment if necessary, or outpatient treatment if that's what most appropriate, and then continue to follow the path of these patients to make sure as best they can that the patients stay on the right path. With someone who's experienced what they're experiencing and who can relate to them and, can call foul on some of the stuff that we know addicts in our life do. The person who is a recovering addict has a much better opportunity of calling foul on some of that stuff than others would. And this helps with their recovery as well. We also have a seed program for about $8 million for recovery housing on our state colleges and university campuses. Rutgers has been a leader in this effort already with recovery housing on their campuses. And we want to incentivize the other state colleges and universities in this state who have a residential population to put aside housing that is reserved for those people who are in recovery. Now, it has been 37 years since I entered college, but I still do remember some of it. And I just say that at least my dorm at the University of Delaware in the fall of 1980 would not have been conducive to avoiding illegal substances, as I recall it. And would not have been a place where someone who is in recovery would find it easy to stay on that path. Might not even find it possible to stay on that path. We need to acknowledge that if our children are getting involved with drugs and alcohol at a much younger age, and we want them to go to college and to advance their education and advance their lives, we shouldn't make it that much more difficult by putting them into a circumstance where the foundational aspect of their life, their recovery, which will allow them to go to class, read, learn, will be challenged each and every evening in a setting where I just remember our RAs, they were not really all that diligent about trying to make sure that stuff wasn't going on in the dorm. In a recovery dorm, though, folks will have the opportunity to have a joint mission for each other. Imagine that all the people in that dorm are in recovery or are trained to deal with those that are in recovery. Imagine the difference between that and a regular dorm for someone who's in the midst of recovery. Imagine how much more supportive that atmosphere is. Imagine what a greater opportunity they have to stay on the path of recovery. And if they do, how much more successful they'll have the chance to be in their studies at our colleges and universities. And so we're incentivizing our colleges and universities to do that. We're also continuing our program, and I like talking about all the programs because, as I said, there's 25 new ones and other expanded ones, and we'll be releasing the entire list of all of them today so that everybody can see and review all of them. But we're also making sure that our medical professionals are incentivized to learn more about what they need to be looking for from the minute they walk into medical school. And so now in this year's budget, it is required of any medical school in New Jersey that receives graduate medical education funding from the state, which, by the way, are all of the medical schools in the state. They must now have curriculum beginning in the first year of medical school on opioid addiction and on prescribing opioids responsibly and on diagnosing those folks who have an addiction problem. These are incredibly important tools in all this. When you remember that according to the CDC, 4 out of every 5 new heroin addicts start with prescription opioids, and that in 2015, 265 million prescriptions for opioids were written in the United States, enough for every adult in America to have a 30-day supply of opioids themselves. The medical profession is a big part of this problem. And I'm not accusing them of doing it purposefully with the intent to harm. The Attorney General has prosecuted a number of doctors who are intending to harm, who are running pill mills in this state. But I think he would even tell you that they are the exception, not the rule. And that the doctors who are overprescribing these drugs just don't know a better alternative. And they don't necessarily understand because they have not been trained to understand what they can be doing to their patients. The Hippocratic Oath is first do no harm. Well, if we're to have them follow their oath, then we need to help to educate them. And that education should start from the minute they put that white coat on in medical school to understand that this has now become a crisis that did not start on a street corner in a neighborhood. This crisis started in a hospital, in a doctor's office, where folks were encouraged to give these drugs when the person receiving them wasn't an appropriate patient to get them, or when too many of them were given out, which helped to lead that person down a path of addiction. You know, as I was putting together the final parts of this, I think it's probably the training of being in this job for now nearly 8 years. Or to be exact, not that I'm counting, 2,801 days as of today, with 119 to go. I tried to say to myself, okay, I'm going to read this and try to figure out who's going to criticize this and why. I had a hard time as I looked at this. These are absolute goods. But I will guarantee you that there will be some ignorant jerk, most likely in a newspaper, who will criticize this, will find some basis to criticize it. What I'd say to all those folks are two things. The first is that the easiest thing in the world to do is to be a watcher rather than a doer. The watchers have the easiest jobs in the world. They get to watch and criticize and never be held to account for their criticism, ever. The criticism comes one day and it leaves the next. For those of us who are doers, we have to be here to be responsible, to be held to account for what we do and what we failed to do. And so if these criticisms come from the watchers, I will deposit it where I deposit all of that criticism, in the wastebasket for the timid, who know nothing of what to do in life other than sit on the sidelines and criticize. I'm here for the people who are living in the arena every day, who are living in the families who are suffering from this crisis. And every one of these programs will help those families. Every bit that we do will help them more. And $200 million is not a small investment, given what we already invest in this issue, but it's necessary to be done. The second thing is that I'm sure there will be folks who will say, where are you getting the money from? Well, let me be really clear. I had a proposal about where to get the money from the supposedly charitable insurance company in this state. And if any of you have dealt with Horizon, you probably have a lot of adjectives for them. Charitable is probably not one of them, even though that's what they're supposed to be there for, to be a charity, a charitable institution that is no longer meeting its charitable mission. But for some reason, one member of the legislature decided that that wouldn't be an appropriate place for the money to come from. I made it clear to the Speaker, and I made it clear to the rest of the members of the legislature, that despite their unwillingness to hold Horizon to account for this, that this would be done. And that's why we got the language in the budget that allows me to move money from any line item in the budget to deal with a public health crisis. We'll detail where all the money is coming from as we move along here and we distribute the money. But no one should fear that we're going to rob from Peter to pay Paul. That's not what this will be. But budgeting is about prioritizing. And when you're the governor of New Jersey, you get to decide the priorities along with the legislature. And when the legislature empowers me to take money from anywhere in the budget in order to deal with a public health crisis, then I just assume they meant what they said, that I could take the money from anywhere in the budget to address this public health crisis. When we are experiencing a loss of life that is equal to the loss of life on September 11th every 3 weeks in this country, that means we have 17 9/11s a year. For those of you who are old enough in this room, and most of you, not you, maybe not Vanessa, are old enough to remember 9/11. We remember how we felt after that loss of life. The body bags being taken out of those buildings and those airplanes. The photos being posted all over New York City and New Jersey, hoping that their loved one wasn't one of the people who died but might somehow still be alive. We remember the pain that we felt for those families when en masse nearly 3,000 people died on one day. We're having that every 3 weeks, except we don't see the pictures. We don't see it on the news. They don't cover it. The carnage that's happening in our country every 3 weeks is not being covered. And so we need to be the people who fight for those families who lose their loved ones. They may have the strength to fight themselves, but sometimes they don't. And we need to be the ones to fight for them. And we need to be their voices. They're overwhelmed. And many of you in this room, I know, because I've met a number of you, have had this problem in your own family. And you know how crippling and debilitating it can be. We have people in this state who care enough about you and your cause to be your voice as well. And that's what today is all about. And everything that we'll be doing from here forward is all about, is about empowering those families and those folks with this disease to be able to recover. I'm pro-life. Some people agree with that, some people won't. That's okay. Everybody's entitled to their own opinion on that issue. But I've always felt, and I've always told the people in my own party, that if you're pro-life, you need to be pro-life for the whole life, not just for the 9 months they're in the womb. I've said, you know, that 9 months in the womb is the easy part. Rarely during those 9 months do they do anything to disappoint us. It's when they come out that things get complicated. And we need to be pro-life, not only for that little baby who I held at Jersey Shore, who came out in withdrawal because of her mother's heroin addiction. We need to be pro-life for the 16-year-old girl who's maybe tonight on the floor of the county lockup here in Newark, who's drug addicted and has nowhere else to turn. We need to be pro-life for the 35-year-old lawyer who became addicted to painkillers and alcohol and is in the midst of ruining his life and the life of his family. We need to be pro-life for the 55-year-old mother who had surgery and never expected in her life that she would get addicted to any drug of any kind. And all she did was take the pills in the bottle that the doctor told her to take. And now she watches her life as a mother and maybe a grandmother fall to pieces. We have to be pro-life for that life too. As I believe that every life is precious and every life is an individual gift from God. And that no life is beyond redemption. But we have to give people the opportunity at redemption and the tools for redemption. And that's what today is about. We hope and trust that this will become a national model for states across the country. We're doing it not only for the people of the state of New Jersey, but we're doing it in our role as chairman of the President's Commission on Opioid Addiction to set an example for the president, for his administration, for the Congress, and for the rest of the country. 64,000 people died of an overdose in America in 2016. That is thousands more than the people who died at the height of the HIV/AIDS epidemic. And I remember the marches on Washington and other major cities to demand action from the government to deal with the death that was going on. Where are our marches? I think that people are not marching in part because they're ashamed, in part because we've so stigmatized this disease that people and their families don't want to be identified with this crisis. They hide in the shadows. The ads that Vanessa and I did in the spring and the ones we're doing together in the fall are about telling people it's okay to ask for help. It's okay to reach out and to get a helping hand through this problem. Doesn't mean you came from a bad family. It doesn't mean you're a bad person. It means you're sick. And for those people who are sick with a chronic disease, we have an obligation as a country to try to treat them. We're not going to save everyone. There will be some who just simply cannot be saved. We understand that. Our obligation is not to save everyone. Our obligation is to try. And that's what this program and the expansion of this program is all about. This is not something that's going to take months to implement. We've been working on it for months. Charlie's report laid out some really detailed things of gaps in our system. Our cabinet commissioners have been working incredibly hard. We have requests for proposal ready to issue for these programs now. They're going to be issued in the next week. We will be awarding contracts before the end of the year. And these programs will start before I leave office. And the reason they'll start before I leave office is because I said they'll start before we leave office. We're not going to leave this to the next person. So it's time to get to work, and we'll be traveling around the state to a number of different really great places like Integrity House to talk about other aspects of the program that I laid out to you with some specifics today, and continue to bring our voice and hopefully your voices to people who are hiding right now, hiding in fear and in shame from getting treatment, and hopefully we get them that, and work with our folks in law enforcement to interdict some of these drugs that are coming in to our country from out of the country, and those that are manufactured here from being distributed and utilized in a way that's damaging to our citizens, and to work with our educators across the state. And we'll be talking about that as well later in the week, to get our education down into grade school. We need to start talking about this in grade school. It is frightening to believe, but it is true, that if we don't get to these young kids in grade school and start talking to them about this, by the time they get to middle school, it can be too late. So we'll talk about all that stuff as we move on the rest of the week. But I want to thank the folks at Integrity House. Nearly 50 years of service in this place with this organization, where they do extraordinary life-saving work. And so they've always made me feel at home here, and I appreciate their willingness to host us today to talk about this issue. And I want to thank all of you who are here for whatever reason that brought you here. It's important. We can do everything we can as a government, but we become much more powerful when the people that we govern walk with us. And by being here today, you're walking with us. Through all the efforts that you've made before today, you're walking with us. And I hope for all the efforts that you'll be inspired to continue and expand beyond today, you'll walk with us. Because if we do, we will deal with this problem. We will save lives. We will make great change for people who really need it. That's why I'm doing this. That's why I believe so strongly in it. And that's why I feel like it's my mission over the last couple of years of this governorship to make sure that not only do we do the programs we need, but that everybody hears that this is a disease, that recovery is possible, and that help is within reach. You just have to ask. So thank you for being here. I know the press is here. They may have some questions. This will be the entertaining part of the program for all of you. Potentially. We'll see. I'm in a fairly good mood today, a little tired. So I might get a little edgy, so hang in there, but we'll see.
Governor, have you given any thought to whether these programs are scalable to the national model and they end up in the report that you're working on for the President's Commission?
Wasn't my first thought on it. I mean, I think we will look at that, and the commission will look at it. We've submitted our plan to the rest of the commission members and to the White House so they know what we're doing. And I'm sure this will be part of the conversation. But some of it's unique to New Jersey, but I think a lot of it could wind up being scalable nationally. But that's a bigger question that we want to take some time over the next month or so to examine the commission along with a number of other issues. We'll be having our next commission meeting on the 27th of September. So a week from Thursday, we'll have our next national meeting in Washington at the White House. And we'll see where we go. I'm sure we'll have discussions that day with a lot of different folks who are coming in to testify, where we'll be able to talk about programs like this and others.
Governor, you said you've been given carte blanche to move money around from wherever.
Yes, sir.
Are there some places where you see the money coming from right now that you can talk about?
There are definitely places where I see the money coming from, but none that I'll talk about at the moment. Today's not to talk about that. Today's to talk about what the programs are and what they're going to do. We'll make it very clear both to the public and the legislature where the money's coming from. What I can tell you is there'll be no vital program that's cut, and there will be no tax that will be increased to do this. We've been pretty good managers of the state's money over the course of the last 8 years, and we'll continue to manage it very well in our last 119 days to make sure that these programs are paid for, and they will be.
Governor, you said this isn't robbing Peter to pay Paul, but by definition, if you're taking money from programs that were allocated in the FY18 budget, doesn't that mean that those programs are either going to have to be cut or changed or eliminated entirely?
Now, I understand why you would think that, never having done a budget before, so let me help you. Every year, there are hundreds of millions of dollars in programs across the budget that don't get spent for a whole variety of reasons. And in the budget vernacular, those are called lapses. And if you look back on our time in the last 8 years, we have had hundreds of millions of dollars each year that wind up getting lapsed into the next year's budget, sometimes in the same line items. Sometimes they get lapsed to spend on other priorities. Sometimes they get lapsed to help to fund reductions in taxes. But remember, a budget document is a planning document, and by its very nature, it's speculative. So you base it, your budget, based upon what you think the utilization in a particular program will be. But in some years, the utilization is much lower. Other times, you'll see at the end of the year that we have to do supplemental appropriations at the end where some programs were more utilized than we projected, and then we've got to take money from a place where we lapsed it and move it to a place where we had overutilization to make sure that we have the money there to spend and that we balance the budget. So no, it's not that. And I've looked at this really closely. This will not involve any kind of significant reduction in any program, nor will it involve the need for an increase in taxes.
But you seem to make a direct link between the Democrats not passing, or Horizon not cooperating with the permanent fund that you wanted, and you called out the speaker. You had signed off in $325 million in Democratic spending priorities as part of that budget deal. Does this mean that those budget deal priorities, that $325 million in additional spending, is going to be impacted as a result of these?
I'm sure that's what they're worried about, but they shouldn't worry. No, I don't see any of the money significantly coming from that $325 million. No, and the reason I called it out was because then I wouldn't have to impact anything at all. Because let me tell you, as a governor, it's good to have those lapses, because sometimes revenue doesn't reach what you projected it to be. And so it's good to have the opportunity to have those lapses to be able to balance a budget at the end, so you don't have to cut programs to balance a budget if revenues don't meet your projections. So I'm sure that the next governor would like to have as much in lapses as he or she possibly could available to them to be able to work the end of this budget and also to create a surplus for the next budget. That would have been more possible if the speaker had not sold out to Horizon and decided that it was more important for them to keep billions of dollars in surplus that they don't use and they're not at risk for. But for whatever reason, the speaker sold out. We all know he sold out. I think we've seen events that have happened since the closing of the budget that make it pretty clear what he sold out for. And, you know, the folks he sold out for are pretty wealthy folks who've donated a lot of money to causes he likes. So you can all make your own conclusions on that. In the end, though, your conclusions on budgeting are on a surface logical, but unfortunately uninformed based upon my experience as governor for the last 8 years. Yeah, Claude.
Governor, is any of this stuff reimbursable? Would you have any plans to seek reimbursement on the federal level?
Well, part of that depends on the IMD waiver. And if the IMD waiver comes in, and for those of you who don't know what that is, the Institutions of Mental Diseases waiver, which is a Medicaid situation where if you have more than 17 inpatient beds in a facility, you can't be reimbursed for the federal side of Medicaid. We've asked for a waiver of that. We have every indication from the administration we'll get it. So that may bring more money in, Claude, in general for this. But this $200 million is all coming from state funds. We hope that as part of the national report, that the Secretary of Labor will deal with the other 70% of health plans in New Jersey that are regulated by the federal government, not the state government, because only 30% of the health plans in New Jersey, the employee-provided health plans, are regulated by the state. 70% are regulated by the federal government. If they do that, Claude, and regulate them as we're doing in New Jersey, which is what the report's recommended, then we'll get even more money in through private insurers, which will help as well with these programs. But there's nothing that we need to get reimbursed in order to do these programs, and we don't anticipate any reimbursement. But if we did get additional funds, either through Medicaid, through IMD, or through private insurers, we would use that money just to enhance these programs, not to put money back into state coffers.
Just a quick follow on that, if I could. These private insurers, would they then pay into a fund, or would it be direct reimbursement to those using services?
Direct reimbursement to the policyholders. Yep.
Governor, at CBS2, we have been consistently doing stories on the opioid crisis. Just yesterday, I did a story about the uptick in communities wanting to restart their anti-drug programs like DARE and LEAD, but some of these communities don't have the budget for that. Will some of this $200 million go towards helping communities restart these types of programs?
No. That works in a totally different way. The Attorney General and his office helps in that regard with some of these programs across the state. And again, I think we need to take a new look at the effectiveness of all those individual programs. Part of what the underpinnings of this concept is that we want to get to evidence-based treatment, evidence-based prevention. And so for any of these groups, and I said this in the speech, you're going to have to show us that you're getting results. We no longer are going to fund programs, whether they're treatment programs or prevention programs, that don't provide results just because they make us feel good. What makes us ultimately feel good is that have programs that actually work and help people who are in treatment to stay in recovery, and to help those who have not yet entered the world of addiction to not enter that world. And I think, and this is not being critical of any of those programs, whether you do, DARE or LEAD or any of the other ones. They're all very well intentioned, but they should no longer be judged based upon their intention. They should be judged based upon their results. And this program will all be based on what results do you provide, and you'll be reimbursed and have the opportunity for additional reimbursement for good performance. We want to incentivize the good performers in this arena, and a lot of them are sitting in this room. Who are providing really good results for the patients and the families. That's the way we want to do this, and we want to do the same thing on prevention. We also need to approach, in my view, prevention much differently than we've done before. I have a 17-year-old and a 14-year-old son and daughter. The time of handing out pamphlets in school is over. If my kids get a pamphlet in school, they very responsibly put it in their backpack, and that's where it stays. And they're not reading it. But if it's on their phone, they're reading anything that's coming in over their phone. We have to modernize the way we deal with these issues, not only in terms of the message that we're providing, but how we're bringing that message to them. If it's not on like Snapchat or Facebook or Instagram or one of those, like, they don't know it. Painfully to my friends in the newspaper business, they don't read newspapers. They barely watch news on TV. They get most of the information they get, and my college-age students, college-age children as well, on the phone. They get it on this, or on their tablet, or on their laptop, right? So we need to communicate to them on the prevention side much differently than we've done in the past. And handing out pamphlets in school and thinking that they're going to read them is, I think, kidding ourselves. We may not be comfortable moving into that world, some of us old folks, but we need to move into that world. Yeah, Dustin.
Governor, is it fair to say that this is your final big policy push as governor, and is the $200 million figure a hard number, or could it be more spending before you?
It could be more, it could be less, based on the same principle that I said in answering that last question. Because we don't know what utilization will be. This is based upon our cabinet members' best projection of what utilization would be. But if, a couple of these programs run in children and families become even more subscribed to than we anticipate, well, then we're going to have to find some more money to put in that program for them, because we're not going to turn people away. So it'll depend. It could go a little higher, it could go lower. 200 million, I think, is the best approximation we can make based upon what we're anticipating on past utilization and what we're seeing as need from what our cabinet officers are getting from the providers and the non-governmental organizations out there. So, I think if you're looking 20% on either side, Dustin, you're probably in pretty good shape. So you're looking at maybe between 160 and 240 somewhere in that range. Could be as low as that, could be as high as 240. I wouldn't expect in the first year it would go much higher than 240 or much lower than 160, but 200 is our best approximation at it. We'll get an opportunity to manage this for about 4 months, and then the new governor will have to take it for the rest of the fiscal year. David?
Governor, I wonder if you've given any thought to why we are where we are. Is it as much about an industry run amok as it is about a culture that kind of is very casual about drug use and abuse?
I think the answer to all that is yes, right? The same way there's no silver bullet, in my view, David, to fixing the problem. We didn't get here for any one particular reason, right? We have a medical profession that was clearly undereducated, if not uneducated, on this topic. We have a pharmaceutical industry, in part, which has pushed prescription of these things in a way that did not acknowledge their danger. We have a society that has, America is the most medicated society in the world, especially as it comes to pain. And so all three of those things have entered into the equation, which is why it's so dangerous, because none of those things are based upon socioeconomic status. That can happen anywhere. Any one of those three things can happen in any neighborhood, no matter your level of education, no matter your level of wealth, race, gender, ethnicity, it doesn't matter. And so that's what makes this so much more dangerous than other crises we've even dealt with other types of drugs. Because this one, unlike cocaine, unlike heroin, unlike meth, this starts 4 out of 5 times legally and legitimately in a doctor's office or a hospital. And so I think there's not one answer to cause, David. I think there's at least those three, and there's probably more that I'm not thinking about as we sit here. And there's lots of other professionals who would sit here and come up and tell you a whole bunch of other ones as well. We're probably like ready to get out of their chair and say, you forgot this one. But those are the three that I see and hear about most predominantly, and the ones we've experienced. So I don't think it's any one thing, but I think both things that you mentioned in the premise of your question are both accurate, and a little bit more too. Claude.
Governor, given the economical nature of this problem and the fact that it far outstrips any one state's ability to handle it, I'm curious to know, since you speak with the president regularly, are you optimistic or pessimistic when it comes to the possibility of taking a formal legal step, national emergency declaration, with respect to Stafford or public health services?
Really optimistic, especially after my conversations with him this weekend. He was in New Jersey this weekend. We had the opportunity to speak, and he is anxious to sign this document and is, I think, fair to say, a little bit impatient as to why the lawyers are taking so long. So I got a feeling that when he gets back to Washington, I know he's a little bit consumed right now at the United Nations, but I suspect that when he gets back to Washington, some of the poor lawyers who are working on this problem are going to hear directly from the President of the United States if they haven't already. So I'm very optimistic about it. As I've said to you from the beginning, the President understands this issue. You know, he's had this issue inside his own family. He understands it. And so he's talked about that publicly. And so I think it makes an enormous difference when you've experienced this personally. I think it makes you understand this in a much different way than even very well-meaning people and well-educated folks about this issue on the outside of the problem. It's a bit of the different nature. So I'm optimistic about that. And I was able to talk to him this weekend about all of the recommendations we made in the interim report in some detail and their level of importance. And I'm following up with the White House this week on some of those things where they have some additional questions. So I'm very optimistic about it, Claude. I think he will do this relatively quickly. And remember, too, on the national level, you know, it's been about a little over a month, about 6 weeks or so since we made the recommendations. If we actually get this done within like 8 weeks, that's like neck-breaking time for the federal government. So I'm to be fairly happy if I actually got the federal government to declare a national emergency inside, because believe me, they didn't know we were going to recommend that. We did not preview the report to the White House. We delivered the report on July 31st, and the first time they saw the report was the morning of July 31st. So the president completely entrusted me and the other members of the commission to draft the report and make the recommendations. He did not ask for he or his staff to have the ability to review and vet the report beforehand. He said to me, I trust you to do this. Give me the best ideas and give them to me as soon as you can. So I'm confident that we'll get there.
Quick follow-up. When you say the document, do you have any sense of whether he's leaning towards Public Health Services Act, which would basically allow the government to do more or less what you're doing here in New Jersey, as I understand it, move money around, move services around, versus the Stafford, which would be sort of direct national disaster?
Don't know. He didn't tell me. He didn't tell me which one that he's leaning towards. And as we said in the report, we really don't care which one. The commission is agnostic on whether it's a Stafford Act emergency or whether it's a Public Health Emergency Act emergency, because we believe that either one will enable the president and Congress to bring the resources to bear that they need. They're just different pipelines through which the money moves. But to us, as we examine both statutes, either one could be effective, and that's why we said to him, the important thing is to declare a national emergency. Consult with your staff and your lawyers about which one you think is the best one to do. I do not have a preference, Claude, to be clear, either way, because I think you can make either one work. And depending upon which one he utilizes, the commission will recommend certain next steps based upon that that will be consistent with that plumbing in terms of moving the money.
Governor, in response to my earlier question, you suggested that there's a particular reason why Speaker Creative sold out. Could you be more specific about what you're talking
No,
about?
that's your job. That's your job. I gave you enough. I gave you enough there. If you can't figure it out, then you either don't want to, or you shouldn't have your job. Yeah.
You mentioned, forgive me if you've answered this before.
You're already forgiven, David.
Thank you.
Been around long enough to get pre-forgiveness.
So then let me change my question. You said that the legislature gave you the ability to move funds around if there was a public health crisis.
Correct.
Did that require a declaration of a public health crisis formally?
Yeah, which we did back in January.
You did, I'm sorry.
Yeah, which we did back in January. Remember, at the time of the State of the State, when we made the State of the State address all about the opioid crisis, we signed an executive order at that time declaring it a public health crisis in New Jersey. So the legislature wasn't ignorant about the fact that we had already declared it. So when I was asking for that language, they knew why I was asking. And that was part of the negotiation that went on, David, during those few days. Yeah, right? So that was some of what went on. Yes, sir.
Governor, another thought. Any concerns of the upcoming hurricane, beach erosion?
You know, right now the briefings that I'm getting from our folks do not have a lot of concern about that. But I think once again it shows why we have been so persistent about the dune system up and down the state, which is now almost complete. Now that we've ended our legal battles with Bayhead and Maniloking, the Margate project will be complete, I think, by November. And then we've already begun the work on the northern Ocean County sets of dunes between Toms River and Point Pleasant. And that will complete the dune system then, and we will have a protective dune system up and down the coast where it's needed. So I think when you see something like the hurricane that's well offshore, thank goodness, here, it'll tell you exactly why I'm so persistent about this. Because if that thing made, you know, a harder left turn, we all experienced that now nearly 5 years ago, and we don't want to go through that again. And if we do, we want to have that dune system in place. So I'm glad that the judge has ruled in our favor in the Maniloking Bayhead action. And we're now looking forward to having the Army Corps of Engineers complete that last piece of the project. It, unfortunately for me, won't be done by the time I leave. The only reason it won't be done by the time I leave is because the folks at Bayhead and Maniloking decided to spend a whole lot of money fighting us on it. But we knew all along we'd win, and I think they did too. I think they were hoping to delay it long enough that they'd get a new governor in here, but just a little short. Too bad. So I'm caught.
Related to that, I'm curious if you think, I realize you're not the operator knowledge of the president's thinking on this, but given how hard and how often we seem to be getting hit by hurricanes, is it a harder lift to declare a national emergency using Stafford, given that's the source of funding for FEMA?
Yeah, I mean, listen, I think either one of them is going to take appropriations from Congress. to scale what we're recommending in the interim report, Claude. So you couldn't move enough money around in the federal budget to scale what we want to scale on this. So either one, whether it's Stafford or whether it's Public Health Emergency Act, they're going to require a separate appropriation from Congress or a separate line item within the overall budget to be able to fund this. So that's why I don't think it really matters. Quite frankly, I think, there are some that would argue that having the Public Health Emergency Act is better because HHS would directly administer the bulk of that money as opposed to FEMA. But I think it's you could argue that either way because these programs would be less complex, believe me, than the programs that you have to devise and run in response to an emergency like Sandy was or Harvey now.
Just to follow on that a bit, is there a way to interpolate from the data you gleaned from New Jersey and spreading that out nationally?
On cost?
On cost, what if you want to put the price tag on the national opioid crisis?
Yeah.
This many billion?
No, because I was never all that good at math, so I'm not that good at that. It's like that gets to decimals beyond what my calculator on my smartphone has. So I have a high school classmate who's here today. He remembers I was not sterling in the math. Yeah, it's not sterling in the math arena. So Andy knows that, and he was very good. I was always hoping to sit next to him. Because Andy was pretty good at that stuff. But I don't know, Claude. I'm obviously not being serious, but I don't know. We haven't looked at that yet. Quite frankly, I think that's the obligation of the Office of Management and Budget. We make the recommendations. We don't have the resources to cost it out. But OMB does, and I'm sure that that's part of the process that's going on right now. I haven't asked the president that specifically, but I'm sure that Congressman Mulvaney is sharpening the pencil and looking at each one of the recommendations in the interim report and giving the president a report on how much each one of those would cost to fully implement. But I haven't come up with that information, nor has that information, if it's already available, been shared with me or the commission. Any other questions? All right, so I want to thank the folks again, first and foremost from Integrity House, for hosting us and for their partnership over the last 8 years. It's been a really, really extraordinary partnership. I remember former Governor McGreevey brought me here the first time. He got the First Lady here even before he got me here. How McGreevey works. If I get Mary Pat, I'll get him eventually. So he brought. That's right, ladies first. He brought Mary Pat first, and ever since that time, we have really appreciated our partnership with Integrity House. And I see Jim Curtin from Daytop Village here as well. And I've spoken to all of you in the media and others who have been at Remarks of Mine before. My involvement with this issue began in 1995 as a county freeholder, going up to Daytop Village, which is an adolescent inpatient drug treatment facility in Morris County, and seeing for the first time the work they were doing up there. And I've maintained my involvement with that place in varying capacities for the last 22 years. And they do extraordinary work there, and I'm really happy that Jim is here to support our efforts today and is providing the kind of service that needs to be provided for young people who are in the throes of this problem. And we'll have more to talk about the rest of the week. I don't want to talk about everything today because the good thing is there's too many programs that we're establishing and expanding to be able to stand up here and run through all of them with you. So we'll do that over the course of the next week. This week, we'll have events every day, the rest of the week in different parts of the state to let people know what we're doing. The good news is this isn't like what governors normally propose, which is, this is part of my budget, and if the legislature approves it, then sometime in the next 12 months it might happen. This stuff will be happening in the next couple of months. And so for the families out there who are looking for more help, for the folks who are looking to find a pathway to recovery and ultimately survival, and then beyond that, thriving, more help is on the way. And there is nothing, no greater obligation to the government than to protect the lives and the health of their citizens and their safety. And this clearly falls into that category. So thank you all for being here today. Thanks again to my cabinet. Thanks again to Charlie McKenna for being the architect of so much of this. I appreciate all of your commitment to it. And everyone has played both in their lane and outside their lane on this. Charlie's the the CEO of the School Development Authority. He's building schools in cities for me in his day job. And so, you know, he's not only doing that, but doing this as well because of his past involvement and expertise in this area. So everybody knows how important this is to me and to the people of the state, and everybody in the government is pitching in to make a difference. So thank you all for doing what you've done. I look forward to seeing all of you the rest of this week as we travel around the state to discuss how important this is. And by the way, Dustin, I just realized that I didn't answer the first part of your question. I don't know if this is my last major initiative as governor or not. And the reason I don't know is because, you know, hurricane season doesn't end until November 1st. And I'm a superstitious guy. And I don't want to say that there won't be anything else major I'll be doing with all the things that are stirring up in the Atlantic Ocean. I hope that absent a hurricane, that this is the last major initiative connected with spending that I'll put forward as governor. But I don't want to jinx myself or the state. It's hard to believe that Sandy was 5 years ago already, but it'll be 5 years ago on October 29th. And for me, it was the defining moment of my governorship. And I would prefer for it to remain the defining moment of my governorship and not have another one between now and January 16th of 2018. So absent something really ugly happening in that regard, I think this will be the last major spending program that I'll announce between now and the end of the year. But when you're governor, you never quite know what's going to come up. So keep your fingers crossed and hope that things stay fairly normal between now and January 16th. And then I can hand it over to the next person and let them lay awake at night and think about those things. So thank you all very much for being here. I appreciate it very much. Thank you. We'll be in touch. Yeah, absolutely.
Good to see you again.